Welcome to the PM&R Scholars podcast. The PM&R Scholars is a group of like-minded individuals focused on collaboration, mentorship, research, and networking opportunities in physiatry. The Road to Residency series will feature on-demand sessions with leaders in the field to bridge the gap to residency. Follow along as you start your rehab journey.
Michael Guthrie is a third-year resident in the University of Pittsburgh PM&R program. He studied biomedical engineering and neuroscience at The Ohio State University and graduated from the University of Cincinnati College of Medicine. He plans to pursue a brain injury fellowship and has a special interest in sports-related concussion. Michael, take it away.
Thank you, Brandon. Thanks for the opportunity to present with you guys via PM&R Scholars. I think this is a great opportunity to share ideas and connect with people across the country. Thanks for the introduction. My name is Michael. I'm a third-year resident and done some projects dealing with sport-related concussion and definitely have an interest in the field here. So I'd like to talk today about some of the historical background and more modern approaches to how we evaluate and treat individuals with sport-related concussion. So disclosures for this, first of all, no financial disclosures. I'd like to mention that this presentation does not really focus on chronic traumatic encephalopathy or CTE or the chronic sequelae of concussion, but rather focuses on primarily American football and the NFL as a framework for understanding the modern approach to concussion evaluation and the initial management of concussion. A potential bias I feel like I should mention is that I likely suffered at least one concussion when I'm playing high school sports, including football and lacrosse. So to go over sort of what I'll be talking about, go over the historical background, some timeline of kind of how we got to where we are today, defining the problem as we know it today. We'll talk about the mechanisms of injury and the exact sort of biomechanics involved of what happens when you suffer a concussion, what sort of things we do to prevent this, how we evaluate athletes in the immediate aftermath of concussion, and then what do we do following up in terms of treatment and rehabilitation. So to start with the historical background, I use this article entitled "The History of Neurosurgical Treatment of Sports Concussion." It's a great article. It has some really good pearls, dating back to even ancient history of how we've gained understanding about this sort of mild traumatic brain injury. So to outline some of the things in this article that they talk about, they go all the way back to the Hippocratic body of work from ancient Greece, where they mention that in cerebral concussion, whatever the cause, the patient becomes speechless, falls down immediately, cannot see and hear. Likely this was in reference to ancient warriors in battle that undoubtedly suffered at least mild brain injuries and then had to deal with the aftermath of that in their daily life. Then moving forward, Rhazes, a 10th century Persian physician and pediatrician, was credited as the earliest in history to sort of acknowledge concussion as a separate entity from more severe traumatic brain injuries. Lanfranc of Milan in Europe expanded on the idea of concussion later on by sort of characterizing it as an abnormal physiologic state caused by a commotion or shaking of the brain, and recognizing that it's associated with temporary paralysis of cerebral function. And then finally, getting up to a little bit more modern times in the 19th century, when they started doing autopsies of brains, they were identifying both large hemorrhagic lesions involved in severe brain injuries, but also starting to see smaller petechial hemorrhages. And that was sort of thought to be the mechanism of mild brain injuries at the time. So a quote from the article from a British neurologist in the 1800s likens the mechanism of concussion to intoxication by alcohol. And he says, the first stage of concussion would be one of sudden dissolution. In these cases, the whole nervous system is reduced, but the different centers are not equally affected. An injurious agent such as alcohol taken into the system flows to all parts of it, but the highest centers, being the least organized, give out first and most. The middle centers, being more organized, resist longer, and the lowest centers, being most organized, resist longest. Did not the lowest centers for respiration and circulation resist much more than the highest do, then death by alcohol would be a very common thing. So even back in the 1800s, neurologists sort of recognizing that there was higher cognitive functions and cerebral functions that were affected by these mild brain injuries, and that they weren't necessarily affecting lower neuroanatomical structures. So to shift our focus on the early days of football, Richard Snyder was sort of a pioneer in the field of football-related concussion specifically. And he's quoted as saying, in the early days of football around the 1890s, the best protection afforded a football player was not a helmet, but a bushy head of hair, which not only cushioned the blow to the cranium, but also afforded a fine handle for tackling. And so here pictured is a player around this time era that certainly had a sort of a longer head of hair, that you wonder if maybe they were growing it out to sort of protect their heads from damage in play. And, you know, being in Pittsburgh, I feel like I have to mention Troy Polamalu as a good example of this, as, you know, I'd definitely seen his hair used as a fine handle for tackling after he intercepted my home team, the Cincinnati Bengals, a few times. But I wonder, you know, you have to wonder if his head of hair under that helmet was actually offering him some sort of protection from brain injury. So moving on to some other highlights of really important moments in football history was in the 1905 season, American college football, which was the highest level of the sport at the time. 18 players died and 159 other players suffered serious injuries. So there was a lot of pressure from higher universities, especially the Ivy League schools who were kind of running the show at this point, to meet with President Theodore Roosevelt to sort of come to a meeting and decide how are we going to handle this major safety issue in an American pastime. These meetings actually sparked the formation of the National Collegiate Athletic Association, which remains as the governing body today of college sports. So these discussions led to some rule changes in 1906, including rules against personal fouls, unnecessary roughness, tackling below the knees, and unsportsmanlike conduct. They also established a rule for the passer requiring to be 5 yards behind the line of scrimmage and more protected, as well as a rule that the tackling player must have 1 foot on the ground, or eliminating the so-called flying tackle. They did not have any rules we can see here about requiring equipment or helmets. The first helmets were sort of optional. First mention of leather helmets being worn in a football game was in the Army-Navy game back in 1893. Probably looked something around this design, with sort of a foam inner lining and outer leather straps. So it's quoted that a Navy player was advised by a physician that he would be facing death if he took another hit to the head after suffering some injuries earlier in the season. A local shoemaker fabricated the helmet, and, it's sort of interesting that the local prosthetists or orthotists of the time. And then really it was 30, 40 years later that the first helmets were required in collegiate and professional football. And I'll talk a little bit more about this later. But these were sort of the early days of what they were using for helmets. So here's a sort of a famous picture of what I understand is to be the essence of early 20th century concussion research. I'm not sure what the outcome measures or if this was a randomized controlled trial, but it looks like the three gentlemen in the background are sort of taking notes on how this young guy was handling a hit to the side of a barn. So further progress later on in college football, Dr. Mal Stevens and Samuel Harvey made another report after several decades later, sort of outlining the updates on severe injuries and fatalities. This report noted that tackling was associated with 42% of fatalities, and that, of course, head and spine injuries accounted for a large majority of the fatalities. But also, they saw that there was abdominal and internal injuries occurring at this time point in history. So they made a number of rule changes again at this point that included preseason training and medical examinations, proper equipment for all players to be worn, for all players to wear, better coaching of blocking and tackling techniques, stricter officiating, and physicians present on the sidelines of games. So many of these sort of changes or thoughts remain in place today. So despite these changes, the problem persisted, and pictured here is in 1933, sort of a routine play in a football game where in frame A, the individual is going out to catch a pass and the defender is approaching. In frame B, they collide. C, you see them falling backwards from one another, and in D, they lay motionless on the ground with players overlooking them. So despite these early implementation of some of these rule adjustments and preseason screening and everything, and even starting to wear equipment to protect the players, the problem is still there. So how have we come to our current point? How much further have we come in the current times? We went from this time of sort of optional leather helmets to now we have feature films starring Will Smith as a physician sort of whistleblowing at the entire NFL that this is a major health concern and really drastic change needs to be made. So how far have we come in understanding this? So the good news is that there's been a significant, almost exponential increase in the research as evidenced by the increasing number of publications on concussion or mild traumatic brain injury over the past several decades. This is reassuring at really getting at what the problem is and how we can manage this best. There's also been a series of consensus statements from groups meeting specifically on sport-related concussion, and most recently this occurred in 2017. And they tried to define concussion. And so the definition, simply put in one sentence, they wrote, sport-related concussion is a traumatic brain injury induced by biomechanical forces. This is a little overly simple, and they recognize this, so they attempt to use other identifying features to define the problem. So they include a lot of qualifying statements, such as the blow may either be directly to the head, face, or neck, or it could be somewhere else on the body with force transmitted to the head. And then in terms of the symptoms that you see, that they say typically it results in rapid onset of short-lived impairment in neurologic function that resolves spontaneously. However, in some cases, the signs and symptoms may evolve over a number of minutes to hours. They also note that it could result in neuropathologic changes, but that the acute clinical syndrome reflects a functional disturbance rather than a structural focal injury, and so that you don't typically see any abnormalities on standard neuroimaging studies. And finally, they note that it may or may not involve loss of consciousness, and that the resolution of symptoms may or may not follow a sequential course. So overall, a pretty messy definition of what exactly a concussion is, and there's a lot of sort of qualifying statements that they're trying to broaden this understanding of what could happen to even cause the syndrome that we see in athletes. Of course, any good definition, sort of makes the omission of the involvement of any drugs, alcohol, or other medications, or other prior neurologic or psychiatric comorbidities contributing to the concussion syndrome as well. So to talk about the epidemiology of sport-related concussion, a lot of studies will quote that somewhere on the scope of millions of individuals suffer sport-related concussion in the United States annually. Almost all quotes at this number consider this to be an underestimation due to a likely high frequency of missed cases and individuals not seeking care for milder symptoms or cases that resolve quickly. There's quotes that this costs the healthcare system a significant value each year. Overall, there's a large body of literature that identifies that females tend to be more affected than males, and this is in a number of ways. They seem to be more at risk in certain sports, and when they are affected by concussion, they tend to have unique profiles of symptoms, not necessarily worse overall symptoms, but a unique set of symptoms that is a growing body of literature that could be a talk in and of itself of the gender differences seen in sport-related concussion. There's been some good work outlining the sports involved, and American football sort of leads the way, followed by men's and women's ice hockey, men's and women's lacrosse, women's soccer, and cheerleading, having the highest associated risk for concussion. So transitioning to what we understand of the precise mechanism of how a concussion occurs, in basic terms, it's just an energy transfer from that outside force that ends up being delivered to the head. And this occurs over a short period of time. And that period of time is really crucial, kind of throwing back to a basic concept in physics. The equation for kinetic energy involves both mass and velocity, and the velocity term is squared. And if you think of that in terms of distance and time, it's distance over time, and that term is squared. So the shorter the time period involved, the higher the kinetic energy that's potentially going to be transferred to the head. So less important is the mass of the object being hit, whether it's an individual hitting the ground or another player or a ball like a projectile. But more importantly is the period of time which that force changes. So it's that rapid change in velocity or deceleration that's responsible for the injury. I like to mention here that counter-coup, kind of understanding of brain injury. And this is implicated in more severe brain injury in the sense that when you have like a rapid deceleration, linearly, the brain actually sort of hits primarily on the front end, but then will ricochet back and hit the posterior edge of the brain or the opposite end of the brain that was initially struck. And so you'll see these contusions that are sort of opposite poles of the brain from where the injury occurred. And this is important to consider in concussion because even though we're not dealing with contusions or hemorrhage in concussion, we are dealing with the brain inside of a fluid-filled space with the cerebrospinal fluid coating the brain, and that ability for the brain to rapidly shift back and forth. So I think this concept demonstrates that the brain in that rapid deceleration is moving through that cerebrospinal fluid. Further research sort of outlined exactly what sort of forces were most likely to cause concussion syndrome. So dating back to the 1900s, British neurologists were looking at animal models of concussions, and they did in fact confirm that these sudden decelerations were responsible for the same sort of syndrome that we see in humans, including loss of consciousness without any obvious macroscopic or microscopic lesions seen in imaging or histopathologic studies. They also found that the loss of consciousness or the stunned state induced in these animals did not occur if their head was held steady in position during the impact. And so this can be sort of thought of as if you just apply a force to the head held still over time, it's not really going to cause this syndrome of concussion. And that's sort of intuitive. But maybe another concept that can be applied more dynamically is, boxers really realize this. It's sort of a defensive mechanism in boxing where you sort of are accepting a hit to the vertex of the head, as this is not typically going to cause a knockout or a significant blow that knocks the person back. These forces that are transmitted when the head is held still don't really cause as much damage as these linear decelerations. And not only that, but many researchers using animal models and biomechanical models have shown that the rotational deceleration is more harmful to brain structures than just simple linear deceleration. So on the left in D, the boxer is sort of getting his head whipped back in a straight line, but in E, he's getting that hook to the side where the head's turning to the side, and that rotational deceleration is inducing what's thought to be axonal damage and shear strain, leading to damage in the axons of the brain. So overall, that's a much worse mechanism, larger mechanism of injury than just simple linear deceleration. There's a lot of talk in the definition and everything about it not involving discrete neuroanatomical structures, but these biomechanical models kind of offer a different understanding of this, that perhaps these specific structures are susceptible to the shear strains involved in these biomechanical transfers of force. So specifically, they're finding that they've found for a long time that reticular activating system in the brainstem and corpus callosum both, where there's a large density of axons traveling through the brain are at particular risk of injury. And this completely mirrors what we understand of diffuse axonal injury seen in more severe brain injury, and can actually be picked up on what's becoming now standard neuroimaging studies. And finally, to zoom in on kind of the histopathological mechanism, it's understood that when there's damage to the brain structures, neurons, it disrupts the cell membrane, and the most important thing is it disrupts the ionic balance that's crucial for the normal function of neurons. And this has even been shown in studies to parallel recovery, in that as long as the ionic imbalances remain, the sort of clinical syndrome will persist. And so the thought being that until neurons are able to recover and restore that cell membrane and normal ionic balance, the symptoms of the concussion may persist, and the risk for other dysfunction will continue. So to look at some examples of concussions that occur in sports, try to pull up this video on YouTube that shows some good clips. This a football player, a defenseless receiver, stretching out for a catch and definitely getting whipped around there as he tries to make the catch, but gets hit by the defender. And then here in rugby, there's sort of head-on collision, the players collide, but you even kind of can appreciate that his body and head and neck get turned pretty quickly to the side right away, and he immediately loses control of the ball. Unfortunately, this is certainly an injury affecting the youth, which we need to keep in mind. And again, it doesn't have to necessarily be impact player to player. It can be a projectile thrown at the head that can rapidly turn it. Here's a kickoff play where the player is running, and he's not so defenseless on this play. He sort of saw the player coming, but even despite that, wasn't able to prevent that sort of rapid deceleration and rotation of his head. In soccer, the header is a common cause of concussion. See, this individual goes up, and you may think he's faking it at first, but the blood from his temple suggests that was a pretty significant injury otherwise. But nonetheless, they sort of wrapped up his laceration on his head, got him right back out to the field of play, and then he gets right back involved with yet another header. So this certainly emphasizes the need to really assess patients and understand how they're doing before we're letting them return to play. You see here him heading it again and then sort of stumbling after. So this is an unfortunate design of hockey arenas where there's actually an opening for the player's head and neck to be outside of the rink while they're skating at high speeds. So he kind of sort of gets bumped here with his head exposed to that side wall, and obviously has a very rapid deceleration there of his head turning down. And you see actually a classic fencer response, which I'll talk about in a moment here. But this was just a sign of a severe injury, which required him to immediately get boarded and taken off the ice there. So as we saw there, the fencer response, just a note on that, it's seen as an extension and flexion of opposite arms. It's a similar mechanism to the fencing reflex in newborn infants, or the asymmetric tonic neck reflex. And this is sort of what happens when they turn their neck to one side. The ipsilateral side will extend while the contralateral side flexes. So thought to sort of be a disinhibition of typical cerebral function that occurs in concussion. There's evidence and studies out there that have sort of defined like a threshold of higher mechanical forces that were responsible for the fencer response seen in animals, specifically with forces delivered to the midbrain. And so this study sort of emphasizes that if you see this response in an individual, it means that their brainstem just took a pretty significant blow, and that they really need to be evaluated and taken out of play immediately. And again, I being in Pittsburgh, this was relevant with Mason Rudolph at quarterback just a couple years ago, exhibiting this response on the field of play after taking a big hit. So how are we preventing concussion? What measures are we taking to try to prevent this huge safety concern from ongoing? Well, the rule changes are continuing, and the NFL is making a concerted effort at making rules that are reducing these sort of high-risk plays. When you look at the rule changes, their website does a good job of sort of outlining the timeline of all the different years and what rule changes were made. There's sort of some common themes to highlight, including the kickoff has been a play that's been identified as having a high proportion of concussion injuries from it, and other injuries, musculoskeletal as well. So they're really trying to augment the rules of kickoff to limit the amount of reps that players are going through for that. There's also the other theme of them trying to protect defenseless players, or sort of players that are getting blindsided or crackback blocks, that sort of thing. This is sort of a point of contention, however, because it's really hard to defend or to define what a defenseless player is in a sport as fast as football. These players are moving as fast as they can, turning their head around, trying to catch a ball that's coming at them while simultaneously protecting themselves from defenders. It's really hard to say on a case-by-case basis when people are not defenseless, and this is a common cause of confusions amongst officials and coaches and players, at any given day. So the question is, are these rule changes effective at reducing concussions? Well, overall, as of 2019, the last year that we had sort of a full season of normal data, the number of concussions actually increased slightly. So despite these rule changes, we're still seeing the same sort of prevalence of concussions in the NFL. The league sort of has a spin on it, saying, well, we're identifying more and we're seeing maybe more milder cases and keeping players out of play. So this is overall a move in the right direction. So it's certainly an area for further investigation. So besides the rule changes, there also has been a lot of advancements in helmet design. So from those early sort of optional foam and leather helmets in the early days to now the more modern designs with more advanced materials, there's been a history of gradually adapting onto the standards of using this equipment, dating back to 1973 being the first established helmet and other equipment standards. But it's been sort of a sluggish process to get helmets well incorporated into play, and still remains a point of discussion today as to whether or not additional equipment and more helmet material actually leads to players exhibiting more risky behavior and sort of putting themselves out there more, and giving harder hits on the field of play. So certainly another topic for further investigation and discussion about helmets and concussion. But overall, studies that have looked at if helmets and mouth guards and this equipment is actually preventing the incidence of sports-related concussion, has conclusively said, at least as of 2011, that there was little evidence supporting that any specific helmet or mouth guard was preventing concussions from occurring, and that the problem remained the brain's sort of commotion with inside the skull and the cerebrospinal fluid, and the deceleration was not really prevented from these helmets. There was one design of helmet that showed promise back in this study and continues to be an area of design focus today. And it has traditionally been used in cycling and downhill alpine sports previously. And so how did they understand how to make these helmets that could maybe prevent brain damage and prevent the whole biomechanical process from occurring? Well, they actually took some lessons learned from woodpeckers. So woodpeckers drum their heads against the side of trees thousands of times a day, and do it at a pretty fast rate in order to pierce through the wood. And so scientists have sort of tried to break down what components of their skull are they using to protect their brain. How are they not inducing brain damage by these rapid movements back and forth that they're constantly doing day in and day out? And so they identified sort of multiple different biomechanical components that help reduce this this damage. And so the first being that the top and bottom portion of the beak is sort of uneven and allows for the translation of force through the beak rather than all the way back through the skull. There's also a unique hyoid bone structure in the woodpecker where it's sort of incorporated into their tongue and beak and wraps around the posterior edge of their skull, which helps to transmit the force around the skull rather than through it. They also have this like sort of spongy structure of the forefront of the skull that helps absorb some of the force before it gets to the actual brain. And they have a small volume of cerebrospinal fluid compared to other animals, which certainly helps them sort of prevent that translation of the brain inside the skull. So helmet designers took advantage of these sort of design concepts to design this helmet that did show promise. And so it's called the Multi-Directional Impact Protection System, or MIPS helmet. And the way it works is that there's sort of a layer that that you would put directly on your scalp or skull. And then there's a low friction layer between that and the external helmet. And what this allows is an actual transmission of rotational acceleration to the helmet as opposed to the skull, similar to the design of the skull of the woodpecker. And so this is utilized in skiing and cycling helmets currently, and has been shown in biomechanical studies to reduce rotational deceleration transmitted to the brain. And it's starting to be incorporated in some hockey helmets, as well as football helmets are trying to capitalize on this sort of design technique. There's alternative strategies out there as well with variable promise. This is an example of a patent that I saw for magnetic helmets that would make use of magnets within inside the helmet to repel the forces of other individuals coming in to tackle them, and potentially reduce the forces of a helmet-to-helmet contact. This is a good consideration, but certainly wouldn't eliminate all the different mechanisms that a concussion still could occur. And so obviously further research is needed to continue with the design advancements to see how we can reduce concussions overall. So to transition to how we acutely evaluate patients once they had a suspected concussion, and I'd like to go back to a quote historically from Dr. Billick, who wrote The Trainer's Bible, which was a sports medicine reference back in 1948. So he says, if he shows normal muscular control, complete orientation, does not complain of dizziness or headache, the conclusion must be that the jarring of the brain was quite mild. If the physician approves, the boy may resume play. If there is no urgent need of him, take him out for a rest and further observation. The seriousness of the concussion is not always proportionate to the violence of the blow. A severe fall or blow may result in nothing worse than a momentary sensation of seeing stars, whereas an apparent mild trauma may do untold organic damage. The explanation lies in individual susceptibility, which, as I have repeatedly stressed, is a vital factor in a great number of athletic injuries. Some athletes are susceptible to concussion and may have a number of them. One must seriously consider the advisability of having them quit football. What's that story of going to the well once too often? So in this sort of paragraph that he wrote about concussion, he touches on a number of really important factors. The acute symptoms involved with the immediate aftermath of concussion. He sort of outlines a very basic return to play protocol. He makes note that the mechanism of the hit may not always reflect the actual damage done in the brain. And he makes a comment on the risk factors of individuals that may be more susceptible to concussions, as well as those who have had concussions really need to be considered limiting their play to prevent further severe injury. So the gold standard of acute evaluation of concussion is called the Sports Concussion Assessment Tool, or the SCAT. It's primarily used as a research tool, but is also helpful clinically. And it goes through a number of steps to sort of identify any signs or symptoms that the patient may be demonstrating that would reflect a significant neurologic impairment. And so obviously, it starts with any red flags that would be reported by the patient in the acute evaluation that would be grounds for taking them out of the game. There's also sort of some observable signs that wouldn't necessarily be reported, but could be observed by bystanders, trainers, physicians likewise, including the following. There's also some standardized orientation questions that are used to assess orientation of the patient after they've suffered a blow to the head. And I think these are important and really useful to consider, that if there's an individual that maybe had a borderline concussion and they want to return to play, this is a good way to sort of convince yourself and convince the player that they are or are not appropriate to go back to play. If they can't really orient themselves to what's going on in the game, where they are, what half it is, what's the score, and what's going on in their season, then they're not appropriate to be competing at the level that they need to be, and should be withheld from the game. So that they make note that, you can kind of substitute any other relevant orientation questions, but this is a good standard approach to it. And then this, obviously, if you're evaluating the Glasgow Coma scale of an individual, there's bigger concerns, and this would be more useful if you had made the decision to board the patient and immediately transfer them to the nearest hospital or emergency room. And this would be useful in communicating to the providers there, but sort of less useful for the borderline concussion cases where you need to make a decision of how severe it was. But certainly a consideration for the most severe injuries. And then there's a good emphasis on cervical spine assessment as a component of the concussion assessment as well, with the logic being that if the individual can't express that they're having neck pain or numbness and tingling or weakness, you have to assume that they're not going to be able to communicate that with you if they're having cognitive issues following their concussion. So you really need to assume the worst and board the patient, make sure their cervical spine is stabilized, and to avoid catastrophic injury in these cases. So to take a look at how the NFL has worked to sort of implement this in practice, after we get through this Liberty Mutual commercial, we'll see Patrick Mahomes in the playoffs last year suffering a concussion. It was a pretty mild hit, but as you see him getting up, he's very obviously, not having good balance. He's requiring all his linemen to sort of hold him up, and the medical team appropriately immediately goes and gets him for further evaluation, starts asking him questions and assessing the extent of injury, and you see sort of a blank, vacant stare on his face. So already we have enough information to take Patrick Mahomes out of this game. He needs further neurologic assessment. He needs to undergo the entire complete workup, just based on those few moments of what we saw there. Because even though, again, as Dr. Billick mentioned back decades ago, even though the severity of the hit wasn't that bad, the aftermath was, and he certainly had evidence of some damage done. So I think a good example of the modern sort of acute evaluation and how it's managed. So the NFL Concussion Protocol, to sort of break it down, they utilize modification of the SCAT to determine if a player is appropriate or not to return to the field of play. It can be initiated by anybody on the field, anybody in the booth, any player, any coach, any official that suspects that there may have been a concussion that occurred. And so the first step is getting them off onto the sideline, getting them evaluated in the ever famous blue tents that we see now on a lot of sidelines of football games. So the initial approach that the NFL has is sort of a go, no go thing. If there's any evidence of concern for a significant injury, the player is not allowed to return to play. So that includes loss of consciousness, gross motor instability, confusion, or amnesia in their case. Once you've done that, you can sort of go through your step-by-step history and physical with a focused neurologic exam on the player to determine more accurately exactly what happened and what their injury might have been. Again, if there's any elements that are sort of borderline or inconclusive, it merits further investigation, and really the locker room setting would be ideal. The blue tent is sort of used as a way to isolate the player from distraction and the crowd and everything, but really the rules state that they need to be taken to the locker room if it's a borderline assessment and have repeat neurologic exams as well as the complete SCAT So that sort of outlines how the NFL approaches this, modifications of the acute evaluation to keep their players safe. So now moving forward to how do we treat and rehab these patients once we have identified the injury and we've taken them out of the field of play, what are the next steps? So the history of approach to concussion used to involve a quote unquote cocoon therapy, where there was sort of a prescribed physical and cognitive rest to individuals for an extended period of time, sometimes a few days or a week, depending on the source. But this has not borne out in research. It's actually been shown to be harmful in a number of ways, that this prescribed rest may actually impair recovery. And so there's a good study that demonstrated this in a pediatric population presenting to the ED with mild brain injury, looking at strict rest as a intervention. And they showed that individuals that were given strict rest as their intervention had worse outcomes than those who were given a sort of return to activity protocol and other educational materials. So, if we're not just telling patients to, there's no room for just complete strict rest, then do we just give them medications, or what do we do next? Then the answer is there's no really FDA approved medications that are the first thing that we should go to. Rather, the approach should be a return to play or return to activity with a heterogeneous approach for individuals as they present with a variety of different symptoms. The CDC has sort of outlined this in their Heads Up Concussion initiative that has been a recent effort to define and educate everybody on the return to play protocols. So this would be including youth coaches, parents, players, everybody involved, so that everybody's sort of on the same page of what we need to do now that you've had a concussion. So the return to play protocol basically follows a step-by-step guide, and that you are only allowed to advance to the next step if you're remaining asymptomatic. So the first step would just be returning to your school or regular daily activities, just getting up and out of bed and feeding yourself, getting dressed, doing those sort of activities before you're allowed to return to any sort of physical activity. So as long as you're asymptomatic with that, you can progress to some light aerobic activity. So examples included here. Of note, this would not include weightlifting at this stage. And then you can advance to some more moderate activity, including walking, jogging, biking, and weightlifting. And then further, the next step would be sort of heavy, high intensity training, where you would be allowed to sprint and go full on, sort of cardiovascular training and start sports specific drills, but this would be non-contact. Finally, if you're asymptomatic through all these steps, you could return to practice and full contact drills, and then return to competition if that goes well. In the CDC guidelines, there's really no outline of exactly the timeline of each one of these steps. They don't say you need to do this for 24 hours and then move on to the next step. It's sort of implied that each one of these steps would probably take at least a half day or a full day trial before you could truly know if you're tolerating these activities. So in general, you could consider that it would take at a minimum 6 days to return back to competition for a player that has had a concussion. A note about the importance of this return to play protocol is emphasized by the second impact syndrome. So second impact syndrome can occur from a seemingly minor impact after a previously known concussion. It can then result in severe traumatic brain injury, where you see edema and hemorrhage leading to significant functional deficits and even mortality. It's a relatively rare syndrome, although it is well documented with plenty of case reports of this happening, of mild impacts resulting in significant hemorrhage, and especially affects younger children under the age of 18 years who seem to be at the highest risk of this. The thought is, sort of going back to the mechanisms of injury, that disruption in the neuronal membrane makes it really susceptible to further events of damage. So once that damage has been done the first time around, it's completely unable to brace itself for a second impact, and then sort of catastrophic injury occurs from there with really severe cerebral dysfunction. So again, this emphasizes the importance of following return to play protocols to avoid catastrophic injuries in these athletes, and to always keep this in mind when you're counseling patients at the risks involved when they're returning to play. So to kind of give a framework of how we can approach diagnosis and treatment and this heterogeneous approach beyond just the return to play, my experience here at University of Pittsburgh with Dr. Anthony Contos and Mickey Collins has sort of demonstrated a good framework for approaching this, where they use these clinical profiles to identify different sort of symptom profiles that patients present with. So they've published on this, outlining various different profiles that have sort of consistently emerged in their data over time. And so it's hard to sort of identify these concretely. There's a lot of overlap, and certainly no one individual falls into one discretely. But overall, they've identified these various profiles, including a cognitive or fatigue profile, migraine or headaches, primarily vestibular symptoms or ocular symptoms, and then an anxiety and mood or psychiatric profile. And of course, not everybody falls neatly into these profiles. And again, there's a lot of crossover. There's not just, you don't just present as simply one profile. But overall, this is a really useful way to sort of streamline an approach to diagnosing what's going on after a concussion and how do we manage it. So to go through these one by one, the cognitive profile, the sort of the cornerstone of psychologic testing is the impact testing. Impact testing is established as a clinically useful tool to get both baseline evaluation of cognitive function and assessment of cognitive recovery over time. So the testing takes 20 to 30 minutes to complete, and you can get 4 composite scores from it, including scores focused on verbal memory, visual motor processing speed, and reaction time. And so what's being done nowadays is young athletes are being given this at baseline before the season. In fact, the Pittsburgh Steelers conducted this testing prior to their training camp starting, at our sports medicine center here in Pittsburgh, to gather baseline information on their neurocognitive function. And the thought being that once they have an injury, they can return for testing, see how much it's impairing these different categories of their neurocognition, and then assess if they're recovering over time and things are improving. And so the example sort of shows that case here where the individual has baseline testing, they take a hit and they have impairments, and then over time, they start to show recovery and back towards their baseline. How do we treat it? Well, again, there's no silver bullet with the pharmacology, but there is emerging evidence that perhaps amantadine may be helpful in reducing some cognitive symptoms and impairments, specifically with memory and reaction time for younger individuals that suffer sport-related concussion. So cited here is an article that sort of showed that retrospectively, that amantadine was helpful at limiting some of these symptoms. Evidence is lacking for other neurostimulants in the specific field of sport-related concussion, but in general, the same concepts that you would use to treat other brain injuries apply here, and that you shouldn't necessarily jump right to pharmacology right off the bat, but you should consider it when symptoms are prolonged and not recovering in the expected time course over, at least a couple weeks. To talk about the post-traumatic migraine or headache profile concussion. This has been well documented to be associated with poor outcomes and longer recovery times when it's present. You can also sort of lump in like cervicalgia or cervical neck pain or occipital headaches in this category as well. And again, general treatment strategies apply to other headaches. You don't necessarily want to use medication right away, but in refractory cases, you need to consider different medications that may be really useful and could actually help multiple symptoms that the patients are having. So the vestibular ocular motor screening tool, or VOMS, is useful clinically to identify vestibular and ocular impairments following concussion. So it's a tool that's used both in research and in real physical exams, where you're using these different maneuvers to assess the patient's baseline level of symptoms and then symptoms after they do these specific exercises. And this can inform both the evolving recovery over time if patients are improving with this test, and also highlight the need for ongoing vestibular rehabilitation. So vestibular rehabilitation is really the mainstay of treating when you have impairments in these those sort of maneuvers identified by that screening tool. It's thought to be caused by a disruption of central pathways more so than the peripheral pathways, although peripheral vestibular dysfunction is common in brain injury as well and should be considered. Furthermore, you can categorize these central vestibular issues into vestibulospinal, involving balance and gait, and vestibulo-ocular issues, sort of highlighting these two different profiles. And so the treatment strategies would differ between the two. So for example, a vestibulospinal system would respond well to having patients stand on different types of surfaces, stand in different positions, and do balance with sort of dual attention tasks that are straining their balance system. And these would obviously be important for the sports that they're involved in, and you'd want to see them being successful in these sort of exercises before they return to play. And then the vestibulo-ocular symptoms, if those are primarily of concern, you can do sort of visual tasks alongside balance exercises, including scanning a wall for visual stimuli or tracking a moving ball while doing a balance task. And those would sort of help treat the ocular symptoms. Furthermore, there's other strategies to really work on ocular movements that can be helpful, including Brock strings, which are pictured in the bottom left there, the young girl using a Brock string with various beads at different lengths to sort of focus on them at different lengths, working on trying to get the near point of convergence, so getting to that black and red ball without seeing double is the goal when you're using those. So you sort of go to the point that you see double and try not to provoke too many symptoms, but try to progress it over time, your extraocular motor strength, and improve that. Additionally, another tool you can use is a pencil push-up, where there's sort of two techniques where either you actually will just keep your focus on the pencil and physically move it closer and further away from you, or you can take the pencil and look at it and then alter your focus from the pencil to the back wall and then back to the pencil again. And this would sort of in the same light focus on strengthening those extraocular movements and near point of convergence. And again, these are skills that are going to be really important for athletes in the field of play when they're rapidly scanning for defenders and the ball coming towards them. The anxiety or mood profile is well documented. There's clear associations with both premorbid anxiety and depression and other psychiatric disorders, influencing the recovery trajectory and leading to more symptoms and exacerbations of these after a concussion. So pretty clear link there that psychiatric illness is intertwined with concussions and can be presenting as a unique profile. There's some evidence out there specific to sport-related concussion that cognitive behavioral therapy is helpful. That's sort of intuitive and should be considered as a tool for individuals that are really struggling in this sort of domain after a concussion. And then furthermore, pharmacologic treatment is appropriate after refractory symptoms that aren't improving over time, and these patients that have sort of post-concussive syndrome not responding to conservative measures. And then underlying all these different profiles is the importance of sleep. The work that I did, I had a research session at PM&R last year where we talked about how increased reporting of sleep symptoms were associated with poor clinical outcomes across multiple clinical profiles, but especially the vestibular profile in sport-related concussion. And this just underlines the importance of encouraging good sleep and making sure that your patients are getting good sleep hygiene following a concussion. Initial treatment strategies, again, should aim for conservative measures, but there's plenty of tools out there that can help, like including sleep logs, actigraphy, or otherwise known as activity monitors, and just smartphone and smartwatch apps that can be useful in tracking sleep and giving sort of biofeedback instantaneously to individuals about their quality of sleep and what sort of modifications they need to make to get good sleep and get better symptom recovery across multiple profiles. To reference a study in this specific field, that despite lack of significant symptom improvement, in one study, they showed that melatonin actually influenced connectivity seen in fMRI studies. No, I don't think this is groundbreaking that melatonin may be helpful for sleep and concussion, but I think this actually highlights something different in that the imaging studies are getting more and more improved over time. And we're actually identifying functional connectivity that's relevant for concussion and the recovery of concussion. So just this sort of concept is going to be really important moving forward in the field of concussion to inform future studies for sleep and otherwise. So overall, just to highlight the physiatrist's role in sport-related concussion, it includes pre-participation screening and evaluation of risk before athletes start even playing their sport. Once they may have a concussion, we should be sort of experts in the acute evaluation and understanding the signs and symptoms that are important to identify in the acute setting. After that, we need to be able to guide patients in the optimal rest period and sort of walk them through the return to play protocol. We need to engage patients in these heterogeneous early rehabilitation programs with referral to appropriate services early on in their recovery to really influence the recovery trajectory and prevent these long refractory post-concussive symptoms. So getting patients involved in vestibular rehabilitation or cognitive behavioral therapy to sort of improve their outcomes in that trajectory over time. And then once we have this refractory post-concussive patients, we need to know what sort of behavioral and pharmacologic intervention will be helpful for them. So spanning the entire scope of the individual from, before they even start participating in sport to once they're recovering is our role as physiatrists. And to leave with a final thought from Dr. Schneider, that pioneer in football-related concussion, he was asked if he had a son, would you encourage or permit him to play football? And I really liked his response. He said, if the boy was of high school age or older and with the proper physique, conditioning, and balanced mental capacity, if the boy was supplied with the proper protective equipment, if he were to be taught the proper coaching techniques with the avoidance of stick blocking or spearing, if his coach was a perceptive, thoughtful man who regarded each lad as his own son, if the boy had the desire, I would encourage him to play football. And so with that, I'd like to really thank Dr. Kevin Franzese and Dr. Contos and Dr. Mickey Collins for their mentorship and sort of informing the clinical relevance and background research going on in concussion today. That helped inform my understanding of it. And so at this point, I'll open it up to questions that anybody has for me. I'd love to discuss anything further.
Thanks, Mike. That was a really great and very entertaining presentation as well. And I really like this last image here. I actually thought the woodpecker thing was really fascinating. I'd never really thought about it. How they can do that all day and somehow not be in a coma. So thank you for that.
Yeah.
I do have a few questions for you. I don't want to keep you too long. Just one that I kind of had was, we've clearly come a long way in our understanding, diagnosis, and treatment of concussions. I mean, from no helmets to wearing helmets and these rehabilitation protocols and all of that. But what do you think are some of the most important things that we still don't know about concussion management at this point? Like, what are some of the things that we really need, like missing links, I think, in the management and maybe even in diagnosis of concussions?
Yeah. Great question. So, with these injuries and with a lot of other things in neurology in general, sometimes the actual diagnosis eludes us unless we were to perform these like really high elaborate imaging studies or actually do like biopsy of the brain, which is obviously not practical to do for an athlete who just got a concussion. So I think getting biomarkers, whether that be through neuroimaging studies or even, serum biomarkers. There's serum biomarkers in severe brain injury, and that can identify worse outcomes and sort of inform, risk for certain comorbidities. That I think that's sort of going to be the next holy grail, or the next big funding push in concussion research, is to identify, is there a test that we can do, put somebody in a scanner or draw their blood and say, maybe you feel okay now, but really what this shows is that you're going to be at high risk for having depression, or you're going to have high risk for having headaches, or you're going to have high risk for having a second impact syndrome, something like that. And so getting those like biomarkers identified with this ongoing research will be crucial to really stratifying risk and being completely confident with saying, okay, Patrick Mahomes, you're good to go back in, next week for the playoff game, and this is your risk of getting another injury. And then, extrapolating that to other levels of play in youth and saying, okay, this is exactly when it's going to be safe for you to get back and start playing again.
That makes perfect sense. Yeah, we definitely need to have that. I mean, that is how you can definitively, in a vacuum and in an ideal situation, really decide who is really the highest risk and how best to manage these patients.
Right.
Is there current research going on right now looking for that, or?
Yeah, certainly with the as I referenced, like the functional MRI studies, which is a little bit more research based than truly clinical. It's not really the standard for anybody clinically to be getting a functional MRI study. But what I think is emerging, and especially important in line with the mechanism of concussion, is tractography is emerging as a neuroimaging modality that's going to be, I think, really useful in identifying these like neuroanatomical changes in the brain following concussion. And so it's making use of advanced imaging techniques that can be done in an MRI scanner that focus on tracks within the brain, and so connections between one area of the brain and the other, exactly like the reticular activating system, which has been implicated in injury. So kind of lining that up in a study and supporting its use will further its utility in a clinical setting. It's used I think in the current times more for like neurosurgical planning, especially like, for example, like a brain tumor or mass that they would need to really identify and avoid certain tracks that they didn't want to damage. But as that's emerging and becoming a standard for those patients, perhaps we can support its use as a rapid scan that can be done for individuals with a concussion.
Super cool. You mentioned some, the anxiety and mood disturbance component of, post-concussive disorders. So, and you did mention there's pharmacological therapies for those. Did you, just to make exact recommendations, but, when you were researching this, which therapies did you typically see had the most evidence?
Yeah, so definitely there's a lot of research on SSRIs. There's a lot of information about them and growing understanding because of the widespread prevalence of anxiety and depression. So I think those are a good one to draw from. The evidence is limited for sport-related concussion specifically, but I don't think that limits our use of these medications. We should draw on other studies and our understanding of how they influence recovery in other forms of brain injury and neurologic impairment. So certainly there's evidence that SSRIs are effective in improving that. And you may have the case where an individual had a minor case of anxiety before the concussion, and then had the concussion, it's exacerbated. It would definitely be appropriate to treat that exacerbation, at least in the short term. So I think that's one area where there's certainly evidence that we can draw from to inform our clinical decision making. And then otherwise, I mean, in brain injury, there's there's a infinite number of sort of cocktails you can come up with all the medications, and it's hard to know exactly what the evidence is for. And a lot of the training is sort of anecdotal in brain injury. So unfortunately, we do have to draw on that at times. But in general, knowing the safety profiles of the drugs and the monitoring recommendations would be important. Like a easy example of, somebody's having a mood instability, you could start them on Depakote. You just need to make sure to monitor their liver enzymes as they go forward with it. So, just doing things like that, I think, is a safe and informed approach to using pharmacologic intervention in concussion.
Fair enough. Yeah, that makes sense. And I think one final question that we had was, just in general, not everyone is, a doctor, not everyone is, highly educated in the medical field and science and everything. So, do you have any advice for families of a patient who've had a concussion, and like resources for them to look into? I mean, everyone seems to know what a concussion is, but, just, I guess, more for like the lay person, like, if there's like videos or if there's like support websites, things like that for them to look into, things that we could just kind of send, to our patients and their families when we see them. I think you probably mentioned something.
Yeah. I think the CDC Heads Up Concussion website is excellent. It's very approachable. The whole initiative was intended for that population, and especially geared towards like youth football coaches and other sports, so that both parents and the coaches felt confident, saying, okay, what are we supposed to do? Little Johnny had a concussion. Now it's the coach's decision if he goes back on the football field or not. So it is a scary situation. It's a good consideration. And it's the reason why this is such a common, household discussion everybody's having about concussion. But the CDC really has some great information. If you search Heads Up Concussion, it gives a great outline of return to play protocol. They give a general one. I think they even give sport specific return to play protocols for individual sports. And then other than that, I think establishing with their pediatrician or their primary care and getting a visit early on. Don't let the symptoms fester. Make sure that the physician is seeing the patient within a week of ideally, just to get established with care and determine, are we going to need to start some rehabilitation and other strategies to mitigate the symptoms that are going to come on. So don't shy away. Don't withhold from care just because it's okay to just stay home and sleep. That's not the right approach. We should be engaging them in this return to play protocol, which the website does a great job of explaining, and then getting keyed in with their physician and or a physiatrist to help guide that recovery over time.
Makes sense. Thank you. At this point, that's all the questions that I have. If we have any others, are you open to me sending them your way, and then maybe you can just record your answers?
Absolutely. Yeah, I'd be happy to.
Awesome. Well, Mike, this has been a great lecture. I learned a lot. I know that, and I know everyone that listens to this will learn quite a bit about sport-related concussion as well. And if they're lucky enough to see the video, they can see some of the entertaining videos and fun animations you have. So I think that'll be quite the treat. So thank you so much for doing this. Do you have anything else you'd like to say before we call it for the night?
No, I appreciate you working with me on this and inviting me to do it. It was a pleasure, and I enjoy sharing, spreading the knowledge about it. It's important for us to know in PM&R, and I think it's a good tool for everybody to have: sports med, brain injury, and otherwise.
Awesome. Well, Mike, thank you so much. It's a pleasure to have you, and keep in touch.
All right, sounds good. Thanks for your time.
Yeah, have a good night.